I really want to discuss, again, the different ways in which hypocortisol states can arise. Okay, so if you're looking at the central components, and this is not an exhaustive list, but this is all I can fit on this slide. But in the review of the literature, these are all potential mechanisms whereby cortisol's message may not get through. And the most commonly seen is basically an over-adaptive response to excess cortisol states. Okay? So you're in medical residency and you're running around and you have no time to eat and no time to sleep and your cortisol is really high. And your reward for graduating from medical school is hypocortisolism, because you can't make it to your graduation because you're on the bed exhausted. You're tired. So what's happened? Your body has compensated accordingly, okay? I'm making so much cortisol, I need to do something to prevent the tissue damage that's going to ensue, because I need cortisol there in high amounts in short periods of time to ensure my survival. But if that process doesn't go away, the body needs to then adapt to prevent the tissue damage from ensuing. So you get the negative feedback, which I know all of you are familiar with, and what does that do? That tells the adrenal glands, okay, shut down cortisol production, please, but I'm not going to let you turn it back on. And it's an oversensitivity, an overreaction to an initial hypercortisol response. And that's what the majority of the literature shows, that this is actually the mechanism whereby low cortisol states primarily arise. But again, traumatic injury to the brain, hippocampal dysfunction. The hippocampus is the part of the brain that is responsible for multiple different things, but primarily for memory. And when we're stressed out, we don't remember things. And even when we are not stressed out anymore, because that process can sometimes be permanent, we still can't remember things. So hippocampus actually directs cortisol release. So if the hippocampus doesn't work and cortisol has destroyed your hippocampus, then there's no regulation on that feedback. Okay? Again, examples of ways in which low cortisol states can arise. Now let's look at some of the peripheral reasons. Again, not an exhaustive list, but perhaps the more common ones that have been shown to occur. And it's all about whether or not the message is getting through. The cortisol is being produced, but are your tissues listening to it? Are there enough receptors at the tissue level? Are there receptors at the pituitary level that are going to listen to the CRH? Those are all issues when you're talking about whether or not that cortisol message is going to get through or not. And then there's defects in cortisol enzymes. And the beta-hydroxysteroid dehydrogenase enzymes, and things that convert cortisol into other corticosteroid byproducts and things of that nature. All of those things will be influential when you're looking at someone's low cortisol state. And perhaps, I know one of our colleagues is discussing liver genomics and detoxification, and this is an issue, because if someone has a liver enzyme issue that's responsible for the production and conversion and things of that nature of other cortisol metabolites, then you might not expect to see the proper or the desired treatment result or treatment outcome when you're treating the patients. Now let's talk about the adrenal, the star of the talk. Notice it's the third slide when we're talking about reasons, because it truly is a hierarchy. And the adrenal gland is one player in this really complex stress game that we play every day. Now, when you're looking at adrenal gland causes of low cortisol, most of them have to do with structural issues, gland trauma, gland toxicity with heavy metals or ketoconazole, glandular antibodies, which is the most common cause of Addison's disease. Lack of cofactors. I mean, you can try to tell your children what to do. They might not listen to you, but maybe they'll listen to your spouse. And it's the communication and the joint message that's responsible for them to do what you want them to do. And so in order for the adrenal glands to produce cortisol, you have to have things like vitamin C, and you have to have things like magnesium, and other things that are involved in steroid hormone pathways. And substrate. And actually, if you look at the literature, there is something that has been well recognized, however still debated, which I know you all find hard to believe because we usually don't debate anything in medicine, we all concur on everything. So when you're looking at the critical care literature, there is something known as relative adrenal insufficiency. We assume, of course, probably incorrectly, that people that end up in the ICU have normally functioning adrenal glands, which I don't think is the case for a normally functioning stress response system. But in these particular patients, when you look at them, they do develop a state of low cortisol. But there are several postulated reasons for why that happens. Metabolic acidosis renders enzyme conversion moot, doesn't happen as well. Substrate insufficiency. And the studies will show that some of those patients may improve and their mortality may go down if you give them glucocorticoids, but not all patients experience that. I won't even go there here because this is an eye-opener session. I put this slide on here because I also want you to understand that there are numerous isoforms of the glucocorticoid receptor. And there's a genetic background and a genetic basis to how that works as well. And I'll give you an example. When you're looking at patients who develop coronary artery disease and carotid atherosclerosis, and they have elevations in their cortisol. Cortisol actually works as a pro-inflammatory agent in the endothelial tissue. And some patients who have a genetic variant of that isoform have more susceptibility to developing heart disease because of that susceptibility to the pro-inflammatory effects of cortisol. Okay? It's true for every other hormone. Why wouldn't it be true for cortisol? So cellular dysfunction, translocation of that hormone, all of those things will affect whether or not your cortisol message is getting through the tissue. Now, the unfortunate aspect, I believe, and this is why I'm up here talking to you today, because the unfortunate aspect is that as a conventional physician, I was not trained on consequences of chronic stress and what it does to our bodies. However, there's no dispute in my mind, nor is there a dispute in the mind of all of the people that are writing the thousands of papers talking about stress-induced bodily disorders and stress-induced disease and stress-induced premature aging and stress-induced cancers. Now, if you look at the literature, these conditions that I have listed here for you have absolutely been shown to be positively correlated with low cortisol states, hypocortisolism. We're not disputing the fact that low cortisol states arise. What I am asking you to consider is the multidimensional way in which that situation can arise. Okay, so again, why is this important? Why do we care who says adrenal fatigue? Why do we care if we use the word low cortisol? And this is the reason why I think we should care, because as a conventionally trained physician, I see both sides of this, and I know many of you in this room share the same experience that I do. And we're trying to establish legitimacy, and we're trying to care for our patients, and we want them, when they go see their physicians, to have equipped in their toolbox the ability to discuss with their physician, I have these issues, I have these symptoms, and I need help. And it has been my experience that patients are dismissed, they're shunned, they're told they're crazy, they're given antidepressants for a condition that really, truly exists. They have low cortisol states. We see it all the time. However, if they show up to their physician's office, or if I have a patient who sees one of my colleagues and they tell them they have adrenal fatigue, all of a sudden the doctor's ears turn off and the patient is dismissed. So for that reason, I think it's important to reconsider the terminology. And the other reason is I think if we're going to truly be practicing evidence-based medicine, we need to practice what the evidence shows. And the evidence does show low cortisol. And when you type into PubMed or Medline the term adrenal fatigue, nothing will come up. But if you type in the term hypocortisolism, you'll get all kinds of information. And so I'm submitting to you to consider perhaps using the word, and it's not as trendy, I understand, hypocortisolism. Which describes either a low cortisol state, so patients that you see who have a flattened cortisol release pattern, or perhaps someone who has a flattened cortisol release pattern, but they don't respond to a traditional stressor. That is also encompassed within the definition of hypocortisolism. But HPA axis dysfunction, I think, is a far more accurate way to look at it. And when you're looking at the research, they describe these different conditions as high and low HPA axis activity, overactivity or underactivity. And then, of course, there's impaired glucocorticoid signaling. All of those things can be used, I think, as perhaps more accurate ways to describe the process. Now, this is the other reason I think it's important, because obviously our patients are much more educated, and they're coming to us, and they have this information in hand, and they need help, and conventional medicine has failed them. So, what are our colleagues telling our patients? This is what they're saying. Now, this is from the Chicago Tribune, September of 2010. And I took these quotes directly from that article. And there have been others, and there's now a position statement from the endocrinology people and the hormone organizations, the conventional ones, talking about the lack of credibility and the nonsense diagnosis that adrenal fatigue represents. And this is what they say. It's a worthless diagnosis. And that all of us are trying to make a bunch of money off these poor people who don't feel well. Okay? This particular physician, who is the head of the Mayo Clinic Integrative Medicine Program, Yes and no. Like many things in this arena, it's a grain of truth surrounded by a lot of hype and peddlers of quick fixes. Well, I have the student loan debt to prove I'm not a peddler, and I'm sure all of the rest of you do too. I tend to agree with Dr. Klopp, who is the Director of Chronic Pain and Research at the University of Michigan. And obviously, many of our colleagues that are the directors of the fellowship program and are instrumental in our teaching all are based in Michigan, and they have an excellent integrated medicine program there. And this is what I really think. I believe this gentleman is accurate when he says there's no question that fatigue is at least partly due to the interaction between the brain and the adrenal glands, but is a gross oversimplification of the origins of fatigue to imply that the adrenals are the major cause. And again, in my research and writing and in my clinical practice, that is what I see, and that's what I see. And again, that may explain why some patients don't get better, or they get better with things you might not expect. There's always a cause. Low cortisol states are a symptom of another problem. Just like fibromyalgia, just like irritable bowel, just like fever. When you find someone who has a low cortisol state, keep looking for the reason why it's there. So in conclusion, I'd like to submit to you that in order to properly diagnose and treat our patients with stress-induced bodily disorders, as well as to engender legitimacy among our conventional counterparts who practice evidence-based medicine, as we should be as well, we should re-examine the use of our terminology and perhaps use more accurate terms that give a better reflection of the true complexity of the stress response system. Thank you very much, and enjoy your cortisol elevators this morning.